We're good to go.
I think you're on the, yeah.
Hey everybody, welcome back to Fertility Factor Fiction. It is great to be here with you again tonight. It's a miserable, rainy, kind of cold day in Windsor, so hopefully wherever you guys are, it's better weather than here. We got a good topic tonight. It was suggested by one of the viewers and they wanted to know about endometritis, so we're going to review the impact of endometritis based on the most recent up-to-date data. And I'll touch on a couple of extra studies that are relevant to this. And then we'll take your questions. So interestingly, apparently not everybody signs in for the first part of the show. A lot of people jump on when they can ask their questions. So if you're gonna watch, probably best to watch from the start, because if you ask your questions earlier, they have a higher chance of getting answered. So we don't spend too much time at the beginning. It's only 15 or 20 minutes. Usually closer to 15. We just try and answer your questions for you. Lots of info this week about COVID, of course, and if you're in Ontario, everybody worried about the lockdown. So the lockdowns have not impacted fertility. None of the fertility centers are closing, so you don't need to worry about that. If you are concerned about the vaccines, certainly the Moderna and the Pfizer appear to be very safe for pregnant patients. There was an article, I think today or yesterday in the CBC, wondering about the impact on menstrual cyclicity or the menstrual cycle. That's not going to have any long-term impact, and there is no way to associate the COVID vaccine with any changes in a menstrual cycle. It could be stress, it could be hormones, it could be the immune reaction. So nothing really major going on there. And then the last part is, should we be using the AstraZeneca or the Johnson & Johnson? And the answer is, as far as everyone is telling us, it appears safe. However, there is an apparent increase in the chances of developing a blood clot, specifically from the virus, that they have been able to detect in studies. And this was just published the other day in the New England Journal of Medicine. And that's only from the AstraZeneca and the Johnson & Johnson. So if that's the case, putting that into a pregnant woman or a woman on birth control could, I emphasize could, in theory, increase your risks. So while there is no direct evidence for this, I am speaking strictly based on what I consider common sense. If you are trying to get pregnant, or are on birth control, maybe push for the Moderna or the Pfizer, because it doesn't have that blood clotting risk associated with it. So probably a little bit safer for you guys. Okay, so hopefully you've all had a chance to grab something to eat or drink. I want to say a very special thanks to our amazing web guy and IT specialist and social media organizer and all things web-based strategy, Tariq Ibrahim, who is practically a doctor, having watched the show a million times, if not in reality, at least in his own mind. So he is not only here tonight with us, but he is also fasting in here as part of Ramadan. So thank you, Tariq, for always being here and being awesome. Okay, so this paper is called Effects of Chronic Endometritis Therapy on IVF Outcome in Women with Repeated Implantation Failure. So essentially what they did was review all of the studies to date that explored women with recurrent failures in IVF to see if treatment or the existence of chronic endometritis actually made a difference. And so what they did was they evaluated a whole bunch of different studies. They finally ended up with 5 that they felt were worthy of consideration. It had 796 patients in the 5 studies altogether. They compiled the data together and then analyzed it based on what the various outcomes and strategies were. And I'll go into that with you in detail. I think the first thing to explain is, what is endometritis? Why does it play a role? So endometritis is any type of infection or inflammation of the lining of the uterus. The lining of your uterus is called the endometrium. So endometritis is inflammation or infection of that lining. How do you get it? Well, you may get it from sexually transmitted diseases, chlamydia, gonorrhea, bacterial vaginosis. There are a variety of them that can cause this. Mycoplasma, ureaplasma can get in there. Even viruses can get in there and cause this. So it's primarily infectious. It can be immune mediated as well, but the ones we mainly look for typically are the infectious sources. How does it look? So if you put up that first slide with the histology, you'll see some glands that are there, which are those sort of circles with the white spot in the middle, and a whole bunch of dark blue or purple colored cells. So those are all immune cells that have migrated into the endometrium because there's inflammation there, and they are trying to take care of whatever inflammation is there. Now they cause some inflammation while they're there as well, but they're there in order to quell the source of the inflammation. And unfortunately, because they are non-specific, in other words, they can kill an embryo as easily as they can a bacteria, when you have that level of inflammation, it's very negative towards your chances of success because your immune system is essentially overactive. It just wants to kill everything that's there. If you look at the next picture, it's a hysteroscopic picture. I've actually never seen someone with acute endometritis hysteroscopically, primarily because I actually don't think it makes sense to do that. You're sticking an instrument into an infected area, which is never a good idea. But this is an interesting picture from a study in 2007 in Fertility and Sterility by Cincinelli, which shows that there are these little fronds, you can see them there, these little sort of outgrowths or projections from the lining, and that's definitely not the way the endometrium is supposed to look. So all of these things can contribute to a reduced chance of success, probably a higher chance of miscarriage, higher chances of failure. So the question is, how do you test for it? And the answer is, the way to test for this is for you to first test and see if there's bacteria, not just in the vagina or at the cervix, but actually inside the uterus. So there's only two ways to do that. One is to do a biopsy of the inside of the uterus, which for years and years has been the traditional method. And the other way to do it is to actually try and either culture or use some sort of diagnostic technology like PCR, polymerase chain reaction, to look for the DNA of the bacteria or the viruses. So in the early phases of all this stuff years ago, we used to use biopsies. So a biopsy is just like a little sampling of the inside of the uterus. It's quite uncomfortable. It lasts about 5 to 10 seconds. You've got to kind of scratch the inside of the uterus, take a sample. The good news, you get tissue, you can actually look at it just like that histology slide we showed you, and a pathologist will examine it and say, yes, this looks like chronic endometritis or acute endometritis, or it looks normal. The bad news, A, it's painful, and B, they only have about 50 to 60% agreement between pathologists on whether a sample demonstrates endometritis or not. So along came some other tests, such as Emma and Alice, which is from iGenomics, the same people that brought you the ERA test. And that test, they claim, can tell you, if more accurately, if there are specific bacteria in the vagina or in the uterus. The problem with that test is it's also not that specific or sensitive in detection. And they actually said to us years ago, when they came to present it to us, that they knew from their own studies that what was in the vagina was not the same thing as what was in the uterus. So we said, okay. And then they said, so we're going to test what's in the uterus with this test. And I said, great. And then I said, how do you treat it? And they said, well, you put probiotics in the vagina and then you hope that it works. And I said, but didn't you just say the stuff that goes in the vagina is not the same as what's in the uterus? And it shut down the whole meeting because they literally didn't have an answer. The more modern technique is to actually use PCR to analyze as many bacteria and viruses in the uterus as possible. And for that, the company we use is called Fertilization. No financial association with them. They're just a good company. It is relatively expensive, but it's very easy. You actually just collect your menstrual blood, you send it to them, they tell you what's in there, and then you can treat it and move forward. And because it's repeatable, we can actually test to see if you've gotten rid of that specific bacteria or multiple bacteria so that we know we're improving your chances. And I've firsthand now seen this work where we've treated patients and it's corrected the problem and we've had success. Does it work for everybody? Nothing works for everybody, but is it helpful? Yes. So in this study, they took these patients that had previously failed. They had a diagnosis of chronic endometritis or non-chronic endometritis, and then they analyzed the data to see sort of what it showed. So if you look at figure 1, so we'll pull up figure 1 for you, and hopefully you guys can see that. Is it above me or below me or below me? So it's right down there, guys. So in group A in figure 1, you can see that there is a very strong association in the favors cured chronic endometritis. So you'll see favors persistent chronic endometritis on one side, and on the other side favors cured chronic endometritis. So in this group, they were essentially comparing two groups, looking at those that persisted in their chronic endometritis versus those that had it cured. And what they looked at was, in the first one, A, the ongoing pregnancy or the live birth rates. And they're showing a 6.81 odds ratio, or in other words, close to a 600% increase above the baseline of success in ongoing pregnancy and live birth. Now, there are few things in the IVF world or in the fertility world in general where you can achieve a 600% increase in success. Those sorts of numbers we never see. 10%, 20%, 12%, 30%, those sorts of things we see all the time. But 600, 700, that kind of thing, we just don't see those numbers. Group B, as you can see there, is about a 300% increase. The odds ratio is 4. And that was for clinical pregnancy rate, meaning you were seeing a heartbeat. And then in group C, you were again at about a 224% increase, all of these highly statistically significant, and that was the implantation rate. So what does this essentially summarize in total? If you had chronic endometritis and you treated it and got it cured, then your success rate massively jumped forwards in terms of success. So we're going to flip down to number 2, figure number 2 now, and here what they did was they compared not just you had it before and you got rid of it, but what if you had it and you cured it and you're comparing it to a group that never had it before. And the importance there is you want to see if you're not just improving the success rates, are you actually normalizing the success rates so that person A who had chronic endometritis can now act like person B who's never had it before. And you can see those diamonds. So when the diamond crosses 1, it means that it is non-significant. So in all 3 groups, live birth in A, clinical pregnancy rate in B, and then implantation rate in C, you can see that all of those cross 1. So it's 0.7 in A, but it's 0.08 to 5.86 for the confidence limits, 1.09 for the clinical pregnancy rate, but again, it goes from almost 0.3 to 4.4, or sorry, 4.1, and so on. So all of these showed that if you treat the chronic endometritis, you actually get the exact same result as someone that's never had chronic endometritis before. Now, the other part of what we worry about with chronic endometritis is that it may not just impact the success of getting pregnant, but it may actually impact the success of staying pregnant. And while they didn't develop a chart or a table for it in this study, their data actually showed when they analyzed it that there was no difference in miscarriage rates between any of these groups either. So what did they summarize from all of this? That if you have chronic endometritis, your success rate is wildly better if you treat it. So the question then becomes, how do we figure all of this stuff out? So number 1, I do recommend some sort of stringent technology or evaluation method. So you either have to have a very good biopsy technique with a trained pathologist that is exceptionally good at figuring out what's there, or you need to use the molecular level technology, which again, we use Fertilization, but any company that does that is great. Once you've got it, it must be treated. Getting rid of something in the uterus from an antibiotic or antiviral perspective is not like taking 3 days of antibiotics for a urinary tract infection. It can take a month. And then you need to be retested to make sure you've eradicated it, because in many instances, we're finding that even after a month of treatment, we're not actually getting rid of it completely. So we strongly favor getting rid of it completely, checking to make sure it's gone, and then proceeding with whatever therapy you want to proceed with. So is it a fact that chronic endometritis has a role? Yes, it's very much a fact that chronic endometritis has a huge role in being a negative for patients trying to conceive, especially with IVF, and that treatment can help. If you've had chlamydia, ureaplasma, mycoplasma, any of those things, it's not enough to just get a few days of antibiotics and think you're treated. It actually is beneficial to do more aggressive testing like we're showing you here, because you may be able to get the right answer. Keep in mind that if your center is doing it with just a biopsy, there is no way to know which bacteria you have, and the antibiotics are quite different. So for example, if you have Gardnerella, which is bacterial vaginosis related, you need Flagyl. But if you have chlamydia, you need doxycycline. Those two are not going to cover each other. So it's very important to make sure you know which bacteria and or virus you're dealing with. And that's why the molecular type of testing is a much better gauge and test. Now, along with this, we had several questions that I do want to quickly address as to, does adenomyosis or endometriosis have an impact? So it's a nice segue into that from here, because endometriosis is when the lining of the uterus is outside of the uterus in your pelvis, and adenomyosis is when the lining of the uterus is in the wall of the uterus. All of those do create more inflammation in the pelvis and inside the uterus, and by doing that give you the same type of result. So you do need to turn down or turn off the adeno and the endo before getting pregnant, because it does significantly negatively impact your success rates. So hopefully you enjoyed that segment of the show. It's a really great topic. Thank you to our viewer who asked us to share that with you this week. Any of those of you that have good ideas or want to know about something in particular, the fertility world is kind of quiet these days with the amount of data that's coming out, and quite frankly, the studies are not particularly earth-shattering right now. So if you have an interesting topic or there's something you want to know more about that you think everybody else would be interested in, don't hesitate to share. We'd be happy to go over that topic with you. So thank you so much for watching that part of the show. We're going to take your questions live now. So hopefully we'll get some good questions, and hopefully Tarek will start eating in two minutes, buddy.
Countdown has begun.
The countdown has begun, yeah. All right, fire away.
Hello. Is spindle view and assisted hatching really helpful? How much of a success rate does it typically have compared to not using these? Also, is it normal to have irregular and shorter period, 2 to 3 months after a laparoscopic surgery?
So you shouldn't really have much of a change in your period after a laparoscopic surgery unless somebody has actually been doing a treatment with surgery into your ovary where they've removed a cyst. If you've had endometriosis, or you had an endometrioma or any other kind of cyst in the ovary and they were damaging the ovary, or not intentionally damaging, but operating on the ovary, you can have alterations in the function of the ovary, which can then lead to alterations in your menstrual cyclicity. With regards to the first part, what was the first part again? Assisted hatching. Spindle view, I have not seen anything convincing on, so I'm not a big believer. It's just expensive technology with no clear proven benefit. Assisted hatching is very controversial. We do use it, and I think most centers do. My previous embryologist used to hatch the embryos before he froze them. I'm not sure why, I could never figure that out, but he insisted that was the best way to do it. Most people, including my current embryologist, hatch them after they are thawed. And that seems to help them get a better chance to implant. Now, this is all based on not doing PGTA. If you're doing PGTA, you actually have to hatch them in advance. So that's a different story altogether.
A lot of people are asking on endo over here. Sorry, I'm misunderstanding. When you say it's important to turn up or down for endo, what does that mean or look like?
Yeah, so what you want to do is make sure you've treated the endometriosis in order to avoid the impact of your immune system being overactive on the chances of getting pregnant. So how do you turn down endometriosis? You turn down your estrogen level. So you either have to use letrozole, Dizan, Lupron, one of these products that allows us to kind of shut everything down in your pelvis, get your endometriosis to go quiet so that your immune system calms down, and that then improves the chances. There's a great study we reviewed a while back looking at unexplained failures in people, and they showed that if you had unexplained failures and you used Lupron and Letrozole for 3 months before an embryo transfer, that your success rate drastically improved. The main reason behind that was theorized to be endometriosis, and clearly that makes sense. If you have endo, you should be on Lupron and Letrozole for 3 months to shut down the endo before you go into an embryo transfer.
If you have if you have had laparoscopy, does this help endo?
Yeah, for sure. I mean, if you've had laparoscopic surgery before, there's no question that that will help your endometriosis, because the whole point of laparoscopy is to either burn or remove the endo. And I know a lot of people out there have read things that say that you have to remove it, it's not enough to burn it. That's actually not true. There's a study that shows there is a 1 point difference in the observed sort of clinical differences between burning, which is called ablation, and excision, which is removal of the endo. Now, if it's a cyst, it's a different story, but if you're just talking about the spots of endo, burning or removal are the same thing. It's going to give you the same outcome clinically as well. And so there's no real significant difference, but treating it either way will have a significant improvement compared to not treating it.
So a follow-up to having the laparoscopic surgery,
Yeah.
even if it was a few years ago having the laparoscopic, does it make a difference?
So endo tends to come back, and usually it'll come back within, anywhere from 3 to 5 years, sometimes even faster depending on how aggressive your endo is. So if it's been a long time, if you've been waiting, months and months and months and then years and years, there's a reasonable chance your endo is back. If it's been more than like 2 years, it's worthy of considering surgery. Keep in mind, it depends on who's operating, how many times you've already had surgery, and how bad it is inside your pelvis. There is a risk with surgery. That risk is the chance that something inside you gets injured. If something inside you gets injured and it's minor, like, you have a nick somewhere and they can put some stuff on it to stop bleeding, that's not a big deal. But if they puncture your bowel or they puncture your bladder, or somebody does some major damage to a ureter or something like that, that's a disaster, and that can have very serious consequences, not just for your fertility, but also for your life. So you got to be really cautious about that.
Do you recommend timed intercourse with letrozole as the first step? I got letrozole with injections to do with timed intercourse. Does it increase chances trying to naturally, or do you suggest medicated IUI?
So it depends on what your diagnosis is. If you have unexplained infertility, letrozole with timed intercourse is actually proven to be useless. So is Clomid with timed intercourse. If you are doing the shots with the letrozole, that also is not helpful for unexplained. But if it's just to improve your chances and you have some sort of explanation, like for example, you have polycystic ovarian syndrome or it's male factor, yes, you will see an improvement. Is it better when you do insemination with it? Yes, of course, it's going to give you a higher chance by integrating the insemination into that process as well. But it's not mandatory unless you have unexplained. So we say this pretty much on every single show. It's probably burned into poor Tarek's brain by now. But if you have unexplained infertility, it's either pills with insemination, shots with insemination, IVF, or surgery to rule out endometriosis, adenomyosis, infection, inflammation, damage to the tubes. Those are the only 4 things which have ever been proven to have an increase in success. So pills alone, timed intercourse, cycle monitoring, it does not help for patients with unexplained. Great question.
Can lining be too thick for FET?
Oh yeah, for sure a lining can be too thick. In fact, my embryologist is so strict, she only wants the lining right at a certain range. So once it starts getting over like 1.2, 1.3, 1.4, the lining is too thick. Our embryologist likes it to be really close to about 8-9 millimeters. So that's what we're traditionally aiming for. We do have some that are thicker, and sometimes you can't get it that thin, but in general, we aim to be around that level. Our protocol right now has worked very well for that, but there are patients where you have to adjust and sometimes even stop and restart in another cycle. But yeah, you can definitely be too thick. If it's over 1.4, 1.6, your lining's too thick for sure.
Age 40, AMH 4.7 nanograms per mil. Started trying last year. Got pregnant on the 3rd try, but had a miscarriage due to chromosome abnormality.
Sure.
Would you recommend trying on our own first or go straight into IUI or IVF?
I mean, if it's taking you a whole year to get pregnant again, then I would definitely recommend seeing somebody, because at 40, even with those very strong ovaries, which you obviously have, the quality of the eggs is not going to be the same, so it will be more difficult. If you're going into it at 40 with that kind of strong ovary, if money is not an issue, I would do IVF, only because you could and should do the genetic testing at that age to make sure the embryos are normal before they go in you, which will not eliminate, but significantly reduce your chances of miscarriage. If money is an issue, IUIs are reasonable consideration. Certainly if you have 2 or 3 eggs at 40, you're going to improve your chances to just having one, which you would naturally produce. So I'm not opposed to that. I think that's a reasonable approach to things for sure.
Good evening. Can the COVID-19 vaccine affect sperm?
Not that we are aware of. No study yet to date has shown that the COVID vaccine can affect sperm. There are a couple of studies that have demonstrated temporary changes in sperm after COVID infection, and overall it does seem to have an impact if you actually get a COVID infection, but the COVID vaccine and COVID infection are 2 totally different things, guys. So they don't behave the same way, you don't respond the same way. Having a raging fever in your body from a COVID infection and that overwhelming kind of immune response that COVID causes is by no means the same as just having the vaccine. Let me ask the next
No,
one.
I got it.
You sure?
Yeah. Do you recommend 1 or 2 cycles after retrieval before starting FVT protocol? Does this matter if you have had OHSS? Thank you.
So if you had OHSS, I'd probably go for the 2, because you want your estrogen levels to come right down. So that's pretty important. If you didn't have OHSS, there's actually a study, I'm trying to remember if it's published already or if it's about to be published. It's one of the 2. It's just out. And they actually showed that there is no difference between the immediate cycle or a subsequent cycle. So you could do either one and it won't make a difference. But if you had OHSS, physiologically it doesn't make sense to go right away, because you want your estrogen levels to go all the way back down to normal. You want your ovaries to shrink back down to normal. You want to feel normal again before you go ahead with your embryo transfers. So for sure. But the study actually showed no difference between the immediate following cycle or waiting 2.
Here's a good question. They're all good questions, but here's one I don't
They're all
know.
good questions. Yeah. Oh, yeah. Here's one he doesn't know the answer to. Yeah, go for it.
How do doctors determine whether patients take PIO injections versus suppositories or a combination of the 2 for an embryo transfer?
That's a great
What
question.
do you normally recommend at your clinic?
So doctors do it based on their preference or based on science. And the science is pretty clear that the PIO injections are superior to just the vaginal. So we actually do both. In my mind, it makes sense for some of it to be in your bloodstream and for some of it to actually be as close to the uterus as possible. So we use the combination of PIO and vaginal for our IVF patients. For IUI patients, we don't, because the PIO is literally a pain in the butt. And as a result, it's a lot of invasive injection for something that is relatively low yield when you're doing insemination. So insemination, we only use vaginal, but for our IVF patients, we're using both. With the rare exception being the patient that either is hypersensitive to the shots or terrified or just can't handle it. Yeah.
What are important supplements do you recommend for 40-year-old women with multiple fibroid issues trying to conceive? Please give the dosage and time to take them. Are the brands really mattering?
So actually, if you have fibroids, the key is not supplements, because there's absolutely no supplement which will shrink a fibroid. So the key is not supplements. The key is, where are the fibroids? How big are the fibroids in your uterus? And are they actually interfering with your fertility? Aside from that, there is some evolving evidence that vitamin D is important in the development of fibroids, meaning a lack of it increases your risk of fibroid development. But there's no evidence that says that if you drown yourself in vitamin D, that it's going to, improve your fibroid size or anything like that. So realistically, you need to be very, very prepared to address the fibroids. And the way to address fibroids these days is to try and either remove them or shrink them. If you're removing them, it's surgical. If you're shrinking them, it's either radiological with an embolization procedure, or medication, which basically suppresses estrogen and or progesterone levels and thereby shrinks the fibroids down. So make sure that you are attempting to determine exactly where and how large your fibroids are. If they're inside the uterus, that's not going to fly. Yep. You need those ones removed.
A lot of questions.
How's the poke bowl?
Oh, surprisingly good.
We had poke for dinner, so there you go. Yeah.
I'm pregnant after 4 miscarriages, and my HCG more than doubled, but my progesterone went down from 89 nanomils per liter to 68 in 3 days. If I started progesterone, can my levels go back up, or is it too late?
No, if you're starting progesterone, your levels will go up. As long as your embryo is genetically normal and your levels are doubling, you should be in the clear. Fluctuations in progesterone early on like that actually have never been shown to be associated with miscarriage. So you don't necessarily have to deal with that, but I would definitely recommend that you follow it. And if it's dipping down more, for sure, we would normally put you on progesterone. You could start vaginal progesterone, it would probably be sufficient. So we use a lot of crinone, so it's 1 twice a day. You can use endometrium, that's 1 3 times a day, or prometrium 2 3 times a day.
I got a loaded question here.
Okay.
Do you recommend norulate
Norlutate?
with Lupron?
I don't know what norlutate is. It's probably European. I'm not familiar with that product, but we use letrozole with Lupron. If you're looking at, if it's a progesterone type product, because sometimes we'll give progesterone with Lupron to minimize the side effects of the Lupron. Fibroids can respond to progesterone, although the studies looking at add-back therapy with Lupron show very, very small incremental regrowth of the fibroids compared to the amount of shrinkage that it can achieve. So it is okay to use it together in order to minimize the side effects of the Lupron. That's if you're treating fibroids. If you're treating endo, you really want to shut off the estrogen. So that's Lupron and letrozole together at the same time. So it kind of depends on what you're treating.
I had a day 5 fresh embryo transfer this month. On the day of transfer, my serum progesterone came back at greater than 240 nanograms per milliliter. Is this too high for a chance at success?
That's really, really, really high. Yeah. You would want that way, way lower than that for an embryo transfer, unfortunately. Yeah. I would not normally transfer if the level was quite that high. Yeah. Now keep in mind, progesterone levels are hard to measure, so it depends on where it was taken from, how it was taken, when it was taken. All of these things can be a factor, but generally speaking, we would avoid transferring if your level was that high. I hate it when that happens.
It's the worst. Hi, Dr. Victory. I had an egg retrieval this summer and had 5 follicles on the retrieval day.
Okay.
I only got 2 eggs and 3 follicles were empty. What might explain empty follicles?
So either you didn't release the follicle, which is possible. They weren't able to fully drain your follicle, also possible. Or you actually had an empty follicle or it was a cyst. So for us, when we're doing a retrieval and we have a low number of eggs, we always use what's called a double lumen needle, which means we can flush back into the follicle after we've drained it. So I'll go in the follicle, so your needle goes in, you drain the follicle, which collapses it. We wait for the embryologist to tell us if she sees an egg or not. She sees an egg, we can pull out the needle, go to the next one. If she does not see an egg, my nurse from outside the body can flush fluid back in, re-expand the follicle, and I can drain it again. Again, we wait and we see, and we go back and forth with antibiotic coverage for the patient to make sure that we have drained every single follicle as much as possible. That allows us to kind of rinse out the follicle to make sure you're getting all the eggs. So just this morning, we had to do that for 2 patients, and we did for 1 patient, we did actually have to rinse out the follicles just to get the eggs. She had 4. I could only get 1 of the 4 without doing the rinsing, but I ended up getting 3 of the 4 with the rinsing. 1, I think, was probably a cyst. That's the main reason. The other possibility is that you did not respond to your trigger. So in some centers, they'll actually monitor your response to the trigger. So if you take LH, they'll measure your LH level. And if you take HCG, they measure your HCG level. And that's a very reasonable approach to things to make sure that your trigger has worked. We double trigger because it works better. And we've shown that on the show in one of our previous videos. So we double trigger all of our patients, but we stopped monitoring for the response because I know it works. And we're covering both bases, both the LH and the HCG for the double trigger. But yeah, that could be the other reason, is that you're not actually responding to the trigger. So for example, if they only gave you 3,000 of HCG and you didn't do the shot properly and you only get, let's say 500 or 1,000, it may not actually be enough in your particular body to cause the release. So in that scenario, you need to take more. And actually, there are studies that have shown that if you stop your egg retrieval midway, measure the HCG, see that it's not high enough, re-administer the HCG, and bring the patient back again 36 hours later, you can actually successfully retrieve eggs. They may be a bit overbaked because now they've gone a full 2 extra days, but at least you're getting some eggs out. Great question.
Norlutate is add-back therapy.
So I addressed that. Yeah. Yeah. So if Norlutate is add back, like I said, if you're treating a fibroid, it's okay. Actually, in that chapter of the textbook on fibroids that I showed you guys at the start of the last, was it the last one or two meetings ago? So in that chapter, we reviewed add back therapy. So it's okay to use add back because it reduces your symptoms, but only lets the fibroid regrow a very small amount. But if you're doing it for endo, you don't want to be on add-back therapy. You want to totally shut everything down.
Please suggest me something. I have multiple fibroids, 39 years old. I want to conceive. Any suggestions?
So again, for those of you who are struggling with fibroids, first of all, watch our video on YouTube from 2 weeks ago. It's already up, and you can check that out because we talk about the impact of fibroids in that video. But just to recap really quickly, if your fibroids are large or they are near the inside of the cavity or in the inside of the cavity, they may need to be removed. If they are smaller, they either may need no therapy or shrinking, in which case they can be done with medicine. There are no natural approaches to treating fibroids, guys. Do not believe anything you see online. Everything is being tested. None of it works.
Links in the comment section for the fibroid video.
Oh, awesome. The link is in the comment section for the fibroid video. So just click that link and always like, share, comment, and subscribe.
Okay. Is it better to use trigger shots a bit earlier than you would for a mature woman than a younger woman? I've heard it's better for egg quality in older women to trigger earlier. What would this age be?
This is a really interesting question. There is no data on this, and I've looked for it because in speaking with someone I have a tremendous amount of respect for in a very, very large program in the US, they told me that they trigger when the follicles are 15 in older women, 15 millimeters. I'm going to tell you flat out that in my opinion that's incorrect because that's too early, although they have a very weird way of measuring as well. So in our program, we do tend to go a little bit earlier. So where we're really looking for like 18 to 20 as the sweet spot, maybe 17 to 20 as the sweet spot for our, average age patients. If you are like sort of looking at 40, 41, 42, will probably trigger when you're around 17, 18. So just like 1 millimeter less than normal. 2 at the most, but we're not doing it at 15. I mean, you're going to get a lot of immature follicles, and the last thing you want in someone who is older is a follicle that's also not mature. So we trigger around the 17, 18 mark, but there's no data. There's absolutely nothing out there that says that's what you're supposed to do. It's like anecdotal, people telling stories of what they've done in their practices.
What is your opinion on using hydrochloroquine during FVT protocol to potentially help with the recurrent implantation failure?
Yeah, so I think it was last year when we reviewed that on the show. We have one on the latest and greatest in recurrent implantation failures and recurrent pregnancy loss. And there is data that shows that hydroxychloroquine actually improves your success rates. So I'm a believer. We haven't used it for everybody. But we do use it for some. There are stronger therapies than Plaquenil, things like subcutaneous IG, IVIG, intralipid steroids, and so on. But Plaquenil is not an unreasonable choice, guys. It's something certainly worthy of consideration.
Hi, Dr. V. I have had 2 cycles with low fertilization rate. Does this indicate egg quality or sperm quality issues, or maybe both?
Yeah, I mean, that's a maybe both question, right? So it depends on how they fertilized you. If they fertilized you with ICSI or conventional IVF, and then it depends on the quality of the sperm and the eggs. Your embryologist should be able to address that for you. If you have very poor quality sperm, then you know it was probably the sperm. If you had very poor looking eggs, they're granular, the zona is very thick, which is sort of the wall around it. You have, very clumped or stuck together cumulus cells. There's all sorts of features. The cytoplasm's dark, it has a dark center, anything like that. Those sorts of features can contribute to the egg quality not being ideal, abnormal shapes, and so on. So ask your embryologist, the person that did the fertilization, especially if they did ICSI, should be able to tell you if the quality is good or not.
Here you go. Triggered last night at 2300. IUI tomorrow at 10. Should we abstain tonight?
Yes. That's an easy one. So definitely don't do it the night before. If your partner has very high sperm DNA fragmentation for IUI, take the sample and run it through the Zymo device because that'll work as long as the count is good and the motility is good. If not, just every 2 days leading up, but definitely not the day before because your count will be lower, and it is important to have a higher count when you're doing IUI for sure. So that's an easy one.
How does the multiple embryo reduction procedure work, and what's the success rate of the rest?
So the success rate is about 5.6% for loss. In other words, you've got a 94.4% chance of maintaining the remaining fetuses that you preserve. It's basically a potassium chloride injection into the heart of the babies that you are doing selective reduction on. So they go in and it immediately stops the heart. It's as humane a procedure as possible in the midst of what can only be described as a terribly difficult procedure, emotionally, spiritually, morally, physically as well. So my heart goes out to those that have to do it. It is something that we have to deal with every once in a while. As our success rates get higher, that becomes more of a problem. So it's not unheard of, but it's definitely something we try to avoid. Yeah.
Mini IVF versus conventional IVF for PCOS. What are your thoughts?
PCOS, I would never go for a mini IVF. That just doesn't make sense to me at all. You're going to do better by having more eggs. So I would go for a full IVF cycle unless money's not an issue. Mini IVF is traditionally used more for people that don't have a ton of eggs and you don't want to take a ton of medication, because in those studies it shows that it doesn't really make a difference. They've got studies comparing mini IVF to conventional when you have diminished ovarian reserve, and there's no difference. But if you have PCO, you want to make a lot of eggs. Not too many, but more.
35 with DOR. Just had first failed IVF with 10 eggs retrieved, 6 embryos, 0 frozen. Was
Wow.
on 300 Agonalef, 150 Luveris, and
Orgalutrin.
Orgalutrin. Sperm is excellent. Any recommendations?
So get all your vitamins checked, see a naturopath, make sure your vitamin D and your iron level are good, make sure your partner and you are not doing anything bad, so smoking, drinking, drug use. Get your partner's sperm DNA fragmentation done. More and more this is becoming an important factor in what we do. In regards to your actual protocol is probably fine because you produce 10 eggs. But you want to maximize your egg quality, so mostly vitamins. There is one study I think we reviewed a year or so ago, which shows that to optimize the genetics of your embryos, you want more of a half-half between recombinant and urinary. You are on Gonalef and Luveris, which are both actually recombinant, so you actually want to be taking a urinary product like Menopur with the Gonalef. I love Gonalef. It's a great product. We use it in almost everybody. But we also use Menopur to balance out that recombinant to urinary ratio so we can get almost 50-50. Those are the main things you could do. Make sure they also didn't overbake your eggs. What I mean by that is some people try to get more eggs, so they wait till your eggs are like 23, 24 millimeters. That's terrible for egg quality. So you want to trigger when your eggs are at like 18, 19. That's going to give you the best egg quality. Otherwise, they're all post-mature and none of them work.
Hi. Thoughts on getting the scratch before FET? Does it help implantation?
So the scratch is an interesting thing. And I've said this many, many times, and we've actually reviewed it twice on the show. So if you have the scratch, about half the studies show that it's useless and half the studies show that it's favorable. And I remember, I think it was about a year and a half ago, literally back to back in the same week, 2 studies came out showing completely opposite results. So the bottom line is nobody knows. Am I a believer? Yeah, kind of I'm a believer. Like I still do it once in a while when I just have no other explanation for why I can't make an FET work. But we really do it rarely now. Very, very, very rarely. Yeah.
He's 37 years old. Estro is high after egg retrieval. 120s after ER. Hasn't lowered. Doctor thinks I might be early menopause. Should I go ahead with FET or wait if it lowers?
That's a good question. If you're doing an FET, you can control your estrogen level. So just take a shot of Lupron or Decapeptyl or whatever you're using, and then go into your FET cycle where your estrogen level won't make a difference. For an FET, your estrogen level is important, but because in most protocols, although not all, like we're stopping use of estrogen almost entirely for most of our FETs, if you are using a protocol that includes estrogen in it, your estrogen level is going to be high anyway, so it won't make a big difference if it's high naturally either. Yeah, good question.
Why do patients have to take dioxazine during an IVF treatment?
Doxycycline?
Doxycycline.
To minimize the chance that there's bacteria. So there's good evidence out there that we've reviewed again on the show showing that the microbiome, meaning the vaginal bacterial environment, is very important, and the uterine. to your success. That's what the study from tonight's Fact or Fiction was about, essentially. So we routinely give all of our patients antibiotics and then immediately treat them with a probiotic to make sure we're getting the best chance of good bacteria being in there. Does it work? No one knows. But it at least gives them the best chance, and it's certainly working for us. I've got the highest success rates we've ever had, and they're incredible. So we're doing a good job, and I think what we're doing makes sense biologically. The data is there to support it, and it's obviously there, clinically as well.
Do pills alone and timed intercourse help with AMH of 3.4?
If it's 3.4 nanograms per mil, then it depends on what your diagnosis is. If it's 3.4 picomoles per liter, it might, but probably minimally. So nanograms per mil, 3.4 is a lot. Picomoles per liter, 3.4 is very low. So if you're 3.4 nanograms per mil, then your AMH is actually on the higher side, in which case it depends on what your diagnosis is. It may help you, for example, if you have PCO, but it's not going to help you if you have unexplained. If you have a 3.4 picomole per liter, you're in the low ovarian reserve component. Letrozole is going to be a very low yield in that kind of situation. You likely need to do something more aggressive, or at least combine it with something like insemination to up the chances substantially. How's your food?
Oh, great.
Was it good?
Oh, yeah.
Did you like it? We tried a new sushi place, so.
That was good.
It was good?
Absolutely.
All right, there you go.
Absolutely. Any advice for coping with a needle phobia when starting IVF? Starting Lupron injection at the beginning of May and then into steps. Feeling very nervous about the whole process.
Do not go into your IVF process nervous. You need to deal with your phobia. So whether we just do a practice run where you're injecting saline or sterile saline, or you go and see a specialist, or you get hypnotized or whatever, if you're stressed going into an IVF cycle, it's drastically going to reduce your success rates. You will artificially inflate your cortisol. You'll be miserable. You won't respond as well. It won't be a good outcome for you. So never do an IVF cycle if you're super nervous. If you're with us, reach out to us and we'll get you the help you need. If you're with someone else, tell them you need help. Don't just jump into your IVF cycle. And if they say, oh, don't worry about it, that's a money grab. That doesn't make any sense whatsoever. Yeah. Now, I will say every single patient gets used to the shots. Even the most terrified patients get used to the shots. So, there's no question it will eventually become something that you're used to and you can get over the phobia. But, make sure you deal with it first. You could always involve somebody else as well so that, you don't have to do it yourself. So whether it's your partner or you hire a nurse to come in and do it, there's all sorts of different options.
Thanks for your above and beyond care, especially last night with JR.
Oh, you are very welcome. Last night was a bit of an adventure for me, but you're very welcome. Always happy to do whatever I can. I was here doing an ultrasound for a patient at 10 and then took her to the operating room because another set of physicians weren't necessarily doing what I thought was the right thing to do. So we got her the help she needed. Throw me a thumbs up if she's doing well. I would love to make sure she's okay. Actually, text me. That would be even better. I want to make sure she's better tonight. So let me know.
What's the typical protocol for an FET at your clinic? What's the average medical protocol and how long does it take to be prepped for the transfer day? Late 20s, PCOS.
Wow, we have a complicated protocol. So we, first of all, make sure everything's perfect in advance. Your hormones, your thyroid antibodies, your vitamin D, your iron level, we check everything. We get you on Lupron on cycle day 21. Then we start you on letrozole on day 3 to day 7. We were monitoring you along the way. We get you on antibiotics and then on probiotics. If you need estrogen, we throw in the estrogen. We have our patients on all sorts of supplements, so melatonin, vitamin D, iron, as I mentioned, DHA, the prenatal vitamins, and depending on your diagnosis, sometimes other things as well. And then we start the progesterone. We make sure your lining shrinks. We make sure you're not contracting too much. We make sure your lining is the right thickness before we shrink it with the progesterone. We monitor your progesterone levels, and then we go ahead and do the embryo transfer. Day 5 embryo, we put in after 5 days of completed progesterone. Day 6 embryo, we put in after 6 days of completed progesterone. And this month, we're going to be trying out Matris to see if Matris works or not. So our beloved nurse, Sarah, is lining some patients up to try that out. So we'll see.
I'm 6 weeks postpartum, C-section and tube removal. When can I get COVID vaccine? Not breastfeeding. Is there a wait period needed?
No, go for it. Right away you can get your vaccine and there's no wait period needed. And actually, there's no contraindication for those of you who are breastfeeding. The antibodies actually will go through your breast milk to the baby and protect the baby. I was just speaking with an Emerge nurse this evening who told me they had a 23-month-old with breathing difficulties from COVID. So for sure, get it checked out. Yeah.
Hi, Dr. V. Thank you for all you do. How can you tell how many eggs are matured by checking E2 levels?
So there is like this really bad, gross estimation of how much estrogen a mature follicle should produce. And depending on your center and your diagnostic technology and so on, you'll get different results. But bottom line is that you can kind of get a sense of where your estrogen should be at, but it's not precise by any means. I mean, I've had times where the estrogen was really high and the eggs were immature, and times where the estrogen was really low and the follicles were mature. So it's not like a one-to-one. Yeah, so, my previous embryologist, once upon a time, a friend, used to say biology is not math. And that was one of the few things I would agree in that it's not math. It's not like you can say, because you have this, it's going to end up with that. So if your numbers are 500, it doesn't mean that you have one mature follicle versus 2 mature follicles.
Thank you. I didn't really understand endometriosis before this.
Oh, cool.
Hey, Dr. V. Does the quality of sperm matter as much as someone is doing ICSI?
Does the quality of the sperm? It still matters because the machinery that makes your embryo pull apart is actually in the sperm. So it's important to still have good quality sperm. Sperm DNA fragmentation, huge negative with fertility, especially with miscarriage risks and so on. So yes, sperm quality is always important. It's less of a concern for fertilization when you're doing ICSI, but it's still a concern overall for the development of the embryo and the blastocyst. And my patient from last night is doing well. They texted me while I was chatting with you guys, so God bless you guys. I'm glad you're well. Sorry for the long night, but I'm glad you're doing better. And thanks for driving all that distance to come out here.
What are your thoughts of dyeing your hair during pregnancy and using
No.
an at-home Doppler?
No. So hair dye goes to your scalp, and your scalp is one of the most absorbent parts of your body. So you're bleaching your kid. So do not bleach my babies because I like my babies unbleached. Let them be whatever natural color they're going to be, please. And so stop using hair dye in pregnancy. With regards to the other part, what was it?
Doppler.
Oh, Doppler. Yeah, there's no harm to using a Doppler, guys, but it will drive you crazy because you don't have the knowledge or skill to know exactly where to look. And if you can't find it, you panic. And what we end up finding is that there are people that have the Dopplers have way more trips to the hospital because they can't find the heartbeat at 13 weeks when it's difficult for me to find it, let alone for someone without the expertise to find it. And so you're just panicking and running into the hospital all the time. So years and years and years ago, we were going to rent them out ourselves. I immediately decided not to do it because it was just going to create terror for people. And that's not something you want when someone's pregnant. It's harmless, but it's physically harmless. It's probably mentally harmful. So don't do it.
Any recommendations for improving egg quality naturally? Thank you.
Vitamins, healthy diet. If you're heavy, weight loss is helpful. We know that for a fact. Exercise has been shown to improve it. Supplements, inositol, NAC, coenzyme Q10, vitamin D, C, E, L-arginine, L-carnitine, resveratrol. Coenzyme Q10 is a big one. Zinc. There's all sorts of natural supplements that can be used. All of those things are really helpful. In terms of other things that you can do, avoid the bad stuff. No smoking at all. No drinking at all. No marijuana or any other kind of drug use at all. Those will help a lot. Yeah.
Can intermittent fasting, Ramadan, affect frozen embryo transfer? For example, transfer is a week or two away.
So Tarek and I were just talking about this before dinner. So you cannot fast when you're trying to get pregnant or you are pregnant. You cannot fast during that time. Arguably, maybe during the time you're trying, but once you're pregnant, you cannot fast. Embryos need nutrition constantly. They don't like go to sleep and then not grow. Even when they're sleeping, they're growing. So you cannot starve the embryo, and especially in a Ramadan like now when it's in the late spring and it's a long fasting period, you cannot fast, guys. So listen, I am very religious. I am deeply respectful of all religions, in particular Islam, but you can't fast. You're not even supposed to fast if you're pregnant, so don't try. There is no reason to fast. God is forgiving. That's all over the Quran. So don't worry, he's going to forgive you if you don't fast. I got Tarek smiling over here.
What's the typical protocol for, we did that. Okay. Does using PDE5 inhibitors and antipsychotic medication for sleep like quetiapine at 25 milligrams as a man hides some risk like birth defects or problems with the child later in life when trying to conceive? So
5-phosphodiesterase inhibitors probably won't. Quetiapine, I don't know. It should be easy to look up on the web. Antipsychotics can raise your prolactin levels. That can suppress sperm production, but it shouldn't cause any kind of birth defect that I'm aware of. But again, each and every medication you're on, and there's so many, it's hard for me to generalize. You should either check with a pharmacist or make sure that you've done your research to know if there are studies in human beings that have shown safety or teratogenicity.
Hey, Dr. Reese. Hello, Dr. Victory. I don't know. I heard recently that for gestational diabetes glucose testing, you don't need to take the glucose drink anymore.
Right.
Instead, blood work is taken and it is sufficient enough. Is this true?
Yep.
Thank you and God bless.
Yes, that's true. We stopped doing the horrid orange drink because we didn't want people staying in a lab for an hour during COVID. So we just do a fasting sugar with your hemoglobin A1C and we can tell from that. Couple more?
Yeah.
You must be tired too, right? You got to wake up at some god-awful hour. What time do you have to wake up for the fast?
Because I feed my kids.
Yeah.
I wake up at 4.
Oh, jeez. 4:20. Wow. All right. Go ahead.
What should progesterone levels be before an FET? Is it important to monitor the first trimester, make sure progesterone doesn't drop?
Okay, so let me answer that backwards. It is absolutely not important to monitor your progesterone levels in the first trimester. First couple of days after the embryo transfer, we usually just do it once, and a couple of days before the embryo transfer, we do it as well, and then check it again if we have to. It depends on your units. With ours, we're looking for 40 to 100. We're in the nanomoles per liter. And I think nanograms per mil, it translates into 10 to 30, if I remember correctly. So those are the ranges we're looking for. If you're under that, you definitely want more. If you're over that, you need to back off.
Thanks for answering the fibroid question. As a follow-up, what supplement in general do you recommend for 40-year-old women trying to conceive?
I think we covered that earlier, so just rewatch the video when it goes up on YouTube. There's all sorts of supplements. coenzyme Q10, all your vitamins, your prenatal iron, vitamin D, which is really important, DHA. Those are like the entry level, and then it depends on your diagnosis.
I think I've heard you recommend IVF patients taking melatonin before. If that is correct, what is the reasoning for that?
So there's a study of melatonin that we reviewed on the show, and it showed a big increase in success. So it probably has to do with improving your sleep habits, and the more rested you are, the probably most likely the better everything is working inside you. But we don't actually know the reason why. Bottom line is it does work better. So we use it for all our patients.
What is the double trigger medication?
So I mentioned it earlier in the show. So a double trigger is taking a GnRH agonist in addition to HCG. So GnRH agonist, the most common one is Lupron. You can use Superfact. You can use Decapeptyl. In Europe, they have some other products as well, Buserelin. So all of those are GnRH agonists. And then HCG is just HCG.
After failed Lupron IVF, on next cycle, I didn't ovulate and keep the egg and ovulate during next period. What is reason?
Not sure I understand that question, but that's super complicated. If there was a follicle there after you did an IVF cycle and it stayed there, it's probably a cyst. It's probably not a follicle. So have a good ultrasonographer look at it and tell you if the edges look really bright, if it's staying the same size, if it's not going away, that's probably a cyst. It's probably not a follicle.
At 44 years old with AFC of 11 eggs,
wow.
What do you think of a protocol? 2 pills of Fermera, 225 follitism, 150 of Menopur, and Omnitrope, and how many retrievals you suggest at 44 with AFC 11 eggs? Thanks.
So the protocol is probably fine. I might go a little higher dose, like 300, but that's fine. In terms of number of cycles, you should watch our embryo math video on our YouTube channel. And for that one, definitely like, comment, share, subscribe. It's a great video. We actually show you how many cycles it takes. It takes about 4 cycles at the age of 43 to get around the 50 to 80% chance of just one baby. So it takes a lot of tries to get a success at that age. It's very difficult, unfortunately, with your own eggs. Your AFC is helpful because you're much higher than what is normal at 43, 44. So your cycle number would be much less. You might pull it off with 2 or 3. At 44, somewhere between 80 to 90% of your embryos will be genetically abnormal. So if you go through the math, what we show you in that video, you'll actually be able to calculate how many eggs you need. It would still be a lot. In order to get 2 embryos that would be normal, you'd probably need somewhere around 20 to 25 eggs off the top of my head. So it's a lot. For sure, it's a lot.
Does CBD have a negative impact on your TTC journey?
CBD, if you mean cannabis, then yes, you cannot use any marijuana, CBD, THC, edibles, vaping, smoking, none of that stuff. It's all terrible for women and it's terrible for men. We just did our marijuana video 3-4 weeks ago. Tarek's putting the link up in a second. That's a great video. So we reviewed it. There's a PowerPoint on it. It shows you what the male side effects are. It shows you what the female side effects are. We went over the fetal effects. You cannot use any element of marijuana when trying to conceive. Marijuana in general is actually not that safe, guys. It shrinks your brain cells. So anything that's shrinking your brain cells is likely not very good for you. So avoid it. Last question.
He's back and he's in command again, so we should have
the Tarek question. Drum roll. I need to get like, you know what we need? We need like a little.
Drum sound?
So
We need like a drum sound, a drum roll sound. You gotta get something
hear
like
us.
that.
There
Yeah.
shouldn't be any sound problems or visual problems.
Oh, here we
Everything
go.
should be good to go.
What does
And we're gonna get started shortly. So
dexamethasone
I actually have kind of a
do
PowerPoint
in
presentation
IVF
for you
stem
guys
protocol
tonight.
endo?
And
How
we'll go
does it
through
help?
the individual little topics. And
In a stim
review
protocol,
everything, and
I'm
then
not
if you
aware
guys
of
have
anyone
questions,
that
I'm more
uses
than happy to take your
dexamethasone
questions.
during the stim.
So, I think
We would
can
use it when
probably
we were
get
actually doing your
started if we've
transfer.
got
We
enough
use steroids,
build
so
up
it's going
there.
to
I
quell
think we're
your
still
immune
waiting for a
response,
few
and
more
it'll
folks
quell
to
the
join
immune
on
response
and,
related to
go
endo
from
as
there.
well. I haven't seen
Really-
studies looking at dex use while you're actually doing the IVF stim, but maybe that's something to do for next show. We can look that up. Yeah, I'll check it out for you. Done?
Done.
All right, guys. So have a great night. Congratulations to Tariq Ibrahim, who managed to make it through yet another day of fasting. How many days is it? 40?
Still, no, 30.
30? Oh, it's 30
or
days?
29, yeah.
Okay, so he's got how many more to go? 20? Yeah,
20 something.
20 something.
Let me know when it's 2.
So for those of you who are fasting out there, congratulations on finishing your fast. If you are pregnant, do not fast. Do not fast. It is not healthy to fast and be pregnant. You can actually pass out, which is risky. For all those of you who are wondering about the vaccines, Moderna or Pfizer, I definitely support. I'm not sure about the other ones, so I'm going to reserve judgment. And for all my pregnant patients, get vaccinated. So I hope you guys enjoyed the show. Make sure you jump on our YouTube channel, like, share, comment, and subscribe, please. We'd love to have more followers there. If there's a topic you want us to review, let us know. And in the middle of the show, we did get a funny comment which said, quote of the night, "Do not bleach my babies." So anyways, have a good night, guys. Take care. Bye-bye.